Hello, everybody. It is 1 p.m. Eastern Time. We'll go ahead and get started here with our presentation for today. Um, Welcome, everybody. Thanks for being here. On the right side of your screen, you can see a few little bubbles here. There's some comments, a little chat area. Feel free to introduce yourselves. Where are you from? What state are you from? Are you in the Southeast? This particular webinar is being sponsored by the Southeast Regional Urgent Care Association, so let us know where you're from, and we'll go ahead and get started here. So, welcome to today's webinar, which is entitled Catch the Wave, Improve Patient Outcomes and Efficiency with Point-of-Care Ultrasound in Urgent Care. And this webinar is brought to you by EB Medicine, Saruka, and Hello Sono. EB Medicine helps urgent care clinicians get up to speed quickly and stay current on the latest evidence so that you can feel confident treating patients in the urgent care setting. Plus, they make earning CME credit easy and affordable. My name is Dr. Patrick O'Malley, and I'm the course director for the laceration course here at EB Medicine, and I'm also a board member of Saruka, and I'll be the moderator for today's event. This presentation will be recorded and will be available to all registrants within 1 week. But now on to today's session, and I'd like to introduce you all to Dr. Tatiana Haverlook. Dr. Haverlook is an emergency physician, formerly ultrasound director at the Brooklyn Hospital, and founder of Hello Sono. Throughout her 15 years of clinical practice, she has relied heavily on POCUS, or point-of-care ultrasound, to make informed clinical decisions, whether it's in an urban emergency department, urgent care, or even Mount Everest Base Camp. Dr. Haverlook is now on the mission to extend the benefits of POCUS to primary care and urgent care practices, as well as rural hospitals, by addressing the key barriers, which are the lack of POCUS competency and infrastructure. She and her team at Hello Sono offer in-person provider training and support with credentialing and implementation to build high-quality, compliant, and profitable POCUS programs. This presentation is about 40 minutes long, and then we'll have a live question and answer session. Enjoy, and take it away, Dr. Haverlook.
All right. Thank you, Patrick. Thank you, Saruka and EB Medicine, for co-sponsoring this webinar. I'm really happy to be here talking to you all about POCUS in urgent care. And just a little bit more about me that Patrick maybe doesn't even know is that I actually completed Wilderness Medicine Fellowship first, and then went on to complete POCUS Fellowship. And really, during my practice in austere environments, including Everest, I really understood the true value of ultrasound when you don't have anything else to rely on in terms of imaging. So I have worked in the emergency departments, urgent cares, and also participated in quite a bit of global health projects. Um, and I think everything else got mentioned. And what am I passionate about? Obviously about POCUS, but really more important is POCUS excellency. And that's one of the reasons why I started Hello Sono is to really bring that high standard of POCUS that we teach our residents in the emergency department outside of their emergency departments. I also love adventure, like mountaineering, exploring, dark chocolate, and skiing. And this is a picture of Everest ER. This is actually a very nice tent with wooden floors, 3 cots, and it's at 17,000 feet. And I spent here 2.5 months practicing medicine with 2 other physicians. And guess what? I was doing ultrasound like almost all the time. And this was our only kind of imaging that we could obtain. Everything else was a helicopter ride away in Kathmandu. This is me doing an ultrasound on a patient with flank pain who had a urinary infection on the urine dip, and I actually ended up finding moderate hydronephrosis on my ultrasound, and I was concerned for infected stone, so I ended up giving him antibiotics, obviously, and then getting him evacuated via helicopter for a possible stent. And ultrasound was just so useful there in terms of diagnosing high altitude pulmonary edema, so looking for those B lines for fluid in the lungs. We even had a pregnant patient, first trimester pregnancy, who was trying to climb Everest, where we actually ruled in an IUP, STEMI, HACE, high altitude cerebral edema, all kinds of things. And one more thing I wanted to mention that many of you might not know, and I don't know when you're going to actually use ultrasound in the cold, but if you do use it, just remember that your gel also freezes, and that's something we dealt with every single morning. We had to do a warm bath for the gel. We also ended up sleeping with our laptops and the ultrasound machine in our sleeping bags just to prevent the battery from dying. All right. Well, this was kind of a little bit of a fun bit about myself. And now that you know about me, I would like to know a little bit more about you. So we have some questions to kind of get an idea of how many of you are using POCUS currently and what's the situation in your practice regarding ultrasound. Patrick, and please go ahead and
Yeah.
comment on the results because I can't actually see them.
Okay, yeah. So 2 votes for reliably on the same day, somebody within 24 hours. No POCUS is being done, but we have clinicians that know how to do it, and nobody is billing for it.
Awesome. All right. Well, I think you guys are in the right place, that means. All right, so today we are going to discuss, well, first of all, making sure we're on the same page. What is really POCUS and why we care about it now? What are the benefits for the patients and the clinicians and the urgent care practice? Some touch upon some evidence behind it. What is the implementation strategy, and following the latest standards, and also what is the potential ROI? All right, just so that we are all on the same page, point of care ultrasound as a clinician provider performs ultrasound at the bedside that is meant to be really focused and quick to answer specific questions and interpret the images on the spot to make decisions. So it's really not the same as a comprehensive ultrasound that you get by an ultrasound tech, then that gets sent. So it probably takes 20 minutes, and then it gets sent to the radiologist to interpret it later on, right? So it's very different. And the cool thing is it's very teachable, and it's also a billable exam that comes with its own CPT codes. And these are just the types of devices that are out there. There is now a ton of them, but they come from handheld devices to um, laptop systems and card-based systems. And there are so many exciting features to select from as well. And why do we care about it now? Well, number one is finally ultrasound is a lot more affordable, and Butterfly was probably one of the first ones on the market that really dropped the price of the ultrasounds, and also they are handheld devices, so they are really, really portable. Number two, we've got a ton of evidence now supporting the use of point of care ultrasound in the emergency departments, in hospital and ICUs, and now increasingly in primary care and also in urgent care settings. So it's been shown to improve diagnostic certainty, increase safety of procedures, decrease length of stay in the emergency departments and inpatients. So a lot of cool stuff, and I'll give you some of that evidence later on. The third important aspect is it really does fit in the value-based care model. So if you are in a bigger part of a bigger healthcare system where really there is an effort to save some healthcare costs, point of care ultrasound is not only patient-centric, but it also helps you save costs by avoiding ER visits and by avoiding more expensive imaging. It's also now backed by multiple organizations from ASAP to ACP to AAFP. ACGME also put out a statement that now strongly encourages family medicine residents get training in POCUS during their residency. So there's really a big push for POCUS to be used in primary care. And the fifth element that I think is important is really provides an opportunity to increase patient volumes and increase revenue and increase the types of conditions you might be addressing in your urgent care by having this tool. So I'm going to start with a case, and maybe in the chat you guys can write down how often you might see something like this monthly. But we've got a 56-year-old man who, let's call him Mr. Google, who is generally healthy. He comes in with left calf pain that's been there for about a day. And the only complicated thing is that he had a flight from California to New York 3 days ago. And of course, he comes in asking you, Doc, do I have a clot? Um, Otherwise, he doesn't have any chest pain. His vitals are fine. His exam is unremarkable, other than some tenderness on his calf. And of course, if you have no POCUS, you're kind of stuck, right? So there is a lot of variability how providers might handle the situation. Some might send this patient to the ER to get a more emergent ultrasound. Some of them might start the patient on an anticoagulant and risk the bleeding complications and wait until Monday to get this ultrasound. But basically, this is not ideal for the patient or the provider. And so you do have POCUS, and you do perform this compression technique, which takes about 2 minutes to perform. And you found no clot, and all of a sudden you can tell the patient, hey, there's nothing life-threatening going on right now. If you still have pain, I would like you to repeat an ultrasound in 3 to 5 days. You can also choose to send a D-dimer and completely rule out a DVT in this low-risk patient. So it really changes your management quite a bit. It improves patient experience in this case, and also saves costs by potentially avoiding the patient needing to go to the emergency department and seek emergent imaging. Patrick, I'm just curious, did anyone write anything in the chat about?
Yeah, so there was something, it was, so who can perform the exam and do they need to be certified? And I imagine that's something that you're going to touch
Yeah,
on
mhm,
with
of
in
course.
a little bit. But I think, specific to this case right here, I just put in the chat that this is something that I see in the emergency department quite regularly. Somebody comes in with leg pain and the automatic, assumption is that it's a DVT. So patients get sent from urgent care with this expectation that they're going to be getting an ultrasound. And sometimes it paints us into an uncomfortable corner, where in my small town community hospital, we don't have ultrasound after hours or on the weekends. So, being able to do this and being able, to get the formal study. So it really does, it's something for us to all be familiar with in the urgent care setting.
Totally agree with you. I worked in 4 different healthcare systems in New York and Colorado. We did not have 24-hour ultrasound in the
Mhm.
emergency department. So, you're lucky if the ER doctor feels comfortable doing a POCUS study and sending this patient home, but otherwise, it might be a lot of wasted time for the patient. And here's just kind of a demonstration of what a blood clot would look like on a compression ultrasound. So on the left side of the screen, this is a fully compressible vein that you're seeing. It's actually a junction of left saphenous vein and a common femoral vein, and they are fully compressible. There are arteries that are not compressible, and they are pulsatile, so that's normal. On the right of the screen, on the screen, you're seeing two non-compressible vessels, and the bigger one is actually a common femoral vein that has a clot in it, and that's why you can't compress. So basically, POCUS would be a great way to rule out, right, as screen patients for a DVT, especially if they are low risk or moderate risk, even in the urgent care setting. So here are some common use cases in urgent care setting. Obviously, we just talked about this: large swelling, pain, rule out a DVT, soft tissue complaints. So rule out an abscess, right? Do we need to be doing an IND on this patient? Looking for a foreign body is another one. Cough and dyspnea, so ruling out or ruling in pneumonia, pneumothorax, CHF. X-rays are actually inferior to ultrasound in their sensitivity for the above conditions. So adopting an ultrasound is a really great way to not expose your patients to radiation, and also deal with the fact that a lot of times we don't have X-ray techs on staff these days. So ultrasound can take place for these conditions. Also, a patient's in flank pain or hematuria, you can rule out hydronephrosis. If there's urinary retention, you can actually do a bladder scan to see whether there is actual urinary retention. Epigastric right upper quadrant pain, thinking about cholecystitis or cholelithiasis, this is quite an easy exam to perform. Definitely musculoskeletal injuries, so ruling out joint effusions, tendon tears, hematomas. You can also look for fractures, especially if you don't have X-rays on site. This is ultrasound is a great way to look, especially for long bone fractures. It gets a little bit trickier if the fracture is in the joint. And of course, procedural guidance. So doing those INDs, foreign body removals, IV insertion, joint aspiration. And I didn't mention ocular ultrasound here or ultrasound, an echo for someone with chest pain, say. All right, we've got two more questions.
A few more poll questions there. What POCUS studies do you believe would be most beneficial to your practice? So everybody go in here and click on the ones. Which ones do you think would be most helpful to you? I know the ones that I tend to use most frequently would be, soft tissue, um, looking for bladder volume before you put in a Foley catheter if they say they can't pee. But what else? Fast exam is pretty commonly done in the emergency department. It's a great way to be able to look for, any free fluid in the abdomen if somebody, more than anything, it just gives them kind of that reassurance. So, yeah, it looks like fast exam, procedural, there's a couple votes here. Renal, bladder, musculoskeletal, soft tissue was the highest with 3 votes. Biggest barriers, 100% is lack of provider competency. I think that's the biggest thing that
Got it.
people struggle with, and liability concerns as well.
Got it. Okay. And we'll address some of those later on in this lecture. All right, so now I'm going to cover some commonly thought of benefits and then some less commonly thought of benefits of POCUS. Well, obviously, improves diagnostic certainty in terms of ruling in or ruling out a DVT, avoiding radiation, especially on your pediatric patients and younger adults. It saves costs for the patient, right, by avoiding ED visits, by avoiding more expensive tests. It's also more efficient for the patient, and I would actually argue it is more efficient for the provider. The 2 minutes you take to do an ultrasound of a soft tissue infection to see whether you need to do an IND, and then potentially finding out that there's not good drainable pocket. You avoid that procedure altogether, and you're saving yourself time. Another way I think about it is, say you don't have an ultrasound and now you need to arrange this follow up. And then not only do you need to arrange this follow up, depending where you work, you might need to, and how concerned you are for the patient, you might also need to call the patient to make sure they got their follow up or potentially communicate their results afterwards, which I think takes a lot longer than doing a 2 to 5 minute POCUS exam. It's also been shown to improve safety and decrease the number of attempts of certain procedures. For urgent care specifically, it would be ultrasound guided IVs, foreign body removal, IND, arthrocentesis. All right, and now kind of less thought of benefits. Well, something we don't think about it, but it honestly, it just guarantees compliance with imaging, right? And I think that's a big thing because I mean, knowing from my own clinical practice, how many times have I told this patient, you must get this Doppler ultrasound to rule out DVT tomorrow morning. And then I look in their chart, a week later and it's never been done. So I think having this guarantee that the imaging is happening is really important for patient care and also for clinicians. I think clinicians' well-being. It enhances patient and provider experience, and I'll touch on that later. It's a marketable skin for the providers. And I would argue it decreases litigation because you're making decisions that are more informed, right? So you're probably starting more appropriate treatments and you're also increasing safety of your procedures. So I think those are really two big things. Um, there has been literature done looking at litigation related to POCUS in emergency medicine and primary medicine fields. And honestly, there hasn't been a lawsuit where misinterpretation of POCUS was an issue. There were 8 cases where POCUS was involved, and the big issue was that POCUS wasn't done with or was delayed when it was available. So it wasn't an issue with misinterpreting, it was really not doing it when you should be doing it. So I hope that reassures some of you that are concerned about litigation. It also decreases ED referrals, which is a huge benefit. And in this day and age, when we are having a lot of shortages of radiology techs, either it's X-ray tech or ultrasound tech, it's a great way to deal with this and mitigate it by having your own providers actually doing some of the imaging. All right, so I have some kind of hand-selected evidence of that I would think would apply to urgent care selected over here. So this is a study out of the ER studying ER physicians, and it found when there wasn't an obvious abscess on exam, and they needed to decide whether IND was indicated or not. 56% of the time they were wrong. So ultrasound would correct them basically to 100%, which is really a great thing to know. And I think this is really making a point that ultrasound, in my practice, it's it's required when there is a patient with a soft tissue infection and potential abscess. There's another study looking at lung ultrasound versus X-ray, and this was on an elderly patient that showed like a huge difference in sensitivity for 90% with lung ultrasound versus 47% with X-ray, looking for pneumonia specifically. There are a lot of studies on lung ultrasound, and maybe the difference is not always as striking, but ultrasound is pretty much almost always more sensitive for pneumonia, for CHF, for pneumothorax. So it's really a great test to be able to offer your patients, especially if you don't have an X-ray available or maybe an X-ray tech available regularly. Another ER study, this was a big study from 2014 or 15, where they did a POCUS first approach for patients with potential renal colic, and they were able to avoid 60% of CAT scans. And they avoided radiation, they decreased their length of time in the emergency department, and they also saved costs for the patients. And this was a really cool study. And honestly, if you do have a patient that's youngish, right, under 60 years old, and they're here with flank pain or hematuria, and you're thinking it's a stone, and you control their pain, and they're afebrile, and their urine is pretty clean, you don't need a CAT scan on these patients. Looking with an ultrasound and seeing that mild and moderate hydronephrosis is what I would expect in someone who is trying to pass a stone, and this is enough to tell them, "Hey, you okay to keep taking ibuprofen, drinking fluids? You're okay to go home and follow up with urologists. You don't need a CAT scan. You don't need to go to the emergency department acutely, unless there are others, risk factors going on." And then another cool study was done where they were able to avoid arthrocentesis 37% of the patients because when they did an ultrasound, there was no fluid pocket to drain, which could be really uh, practice changing in an urgent care setting. And imagine not putting your patient through unnecessarily painful procedure if you could avoid it.
Yeah, and I think those two, the first one and the last one there on your bullet points,
Mhm.
that 56% change. I think I just put this in the comments. Probably everyone who's listening right now has cut into somebody thinking that there was an abscess and there's nothing. If you can just put that ultrasound probe on there and there's nothing to drain, you just made a really big decision and you saved them an unnecessary procedure with unnecessary morbidity by just taking an extra 2 minutes and putting an ultrasound probe on there. It really does have a big impact. I use that all the time in the emergency department for that particular reason.
Exactly. Totally agree. And this is an illustration also, what hydronephrosis looks like and how easy it is to see on ultrasound when you're doing a very focused ultrasound, right? But the only thing we are looking for here is hydronephrosis. We are not measuring the size of the kidney. We are not looking at its parenchyma. We are really looking at for the dilation of the pelvis and the calyces. So fluid looks black on the ultrasound, and the kidney on the left is normal. Kidney on the right has moderate hydronephrosis because we are saying that seeing that black fluid extending the pelvis and also extending into the calyces, thus making it moderate hydronephrosis. So if I saw this with a 30-year-old patient with flank pain and a urine that maybe had a little hematuria, if his pain is controlled, I would just send them home. I wouldn't do much more for this patient.
Mhm.
This is a primary care study, and it basically showed that 92% of the patients felt more thoroughly examined when ultrasound was used, and 95 of them also felt that POCUS improved level of service, and over 60% of them also said that they trusted their physicians more when they used ultrasound. Pretty remarkable if you're trying to kind of get your numbers up in terms of patient experience. And then Journal of Urgent Care Medicine, there are 12 pages of POCUS related articles. I mean, this is pretty cool. Although we don't have huge randomized studies in urgent care right now, we have a ton of case reports. We have a ton of literature right now in urgent care saying, like, hey, you probably should be using POCUS, or POCUS should be part of your pathways, uh, clinical pathways.
That'd be a great research project if anybody was interested. I'm sure you'd be happy
For
to help out
sure.
with that. Yeah.
Oh, yes, I'd love to help out with some research projects. All right, and I have a second case, and this is kind of, we talked about it a little bit, but a 37-year-old female who comes in with um, right groin pain. She's been having it for the last 3 days. There's some swelling, some erythema there. She's afebrile, and basically on exam, it's indurated but not fluctuant. So you're wondering, is there an abscess that needs drainage, or is this maybe a reactive lymphadenopathy, just a cellulitis? So with no POCUS, you can go all kinds of ways. You might be cutting into something that doesn't need to be cut at the moment. You might be giving her antibiotics and telling her to come back in 3 days and risking her becoming septic. None of it is ideal for the patient nor for the provider. And if you were to do POCUS, and honestly, it's like a 30-second exam, you just put the probe right on top of the affected area and you see this, right? This is an abscess. So there's a fluid collection, which is black. You're seeing some debris inside, which is that speckled whitish material. You can actually see how deep it is, how big it is. You can look for loculations. You can even do post-procedure POCUS to make sure you got most of the pus out. And you can put color flow to make sure this is not vascular, and make sure there are no vessels anywhere on the surface that you might be by accident cutting into if you're doing an IND. And this patient receives their IND, probably some antibiotics, and they probably don't need to come back and see you again. So I think this is really a huge benefit of POCUS in terms of patient care and saving costs and efficiency in terms of for the patient. So what's the impact on the patient? I think the biggest thing is they're getting better care. They are saving time by avoiding going to emergency departments, radiology centers. They are understanding diagnosis better because you can actually show them what's going on, and they get to pay less. So, it enhances overall experience that they are having. And then what's the impact on the provider? A couple of things. Well, they get to acquire a new skill. They also get to keep up with the new standards. And that's something I recently looked into. Although um, so most of the urgent cares are staffed by mid-level providers, the POCUS education in NP and PA schools is on the rise. Right now, the latest study I saw, 29% of PA schools were offering POCUS curriculum. So I think as we keep going forward, we are going to see PAs and NPs graduating expecting to be using POCUS when they practice. It's part of what they are learning. So I think this is a really exciting time.
I think also
And
it'd be interesting,
yeah.
whoever's in here, if you are a PA or a nurse practitioner, did you get any ultrasound training or exposure? Feel free to drop that down in the chat. And there was a poll question here. What would be the top 3 reasons for you to introduce POCUS into your practice? And it looks like patient satisfaction and improved patient care are the main areas of interest.
Awesome. Good to hear. We've got some good people here. Um, Another impact of a provider would be avoiding that frustration of making a decision on something that you don't have enough information about, right? Or the frustration of arranging that follow-up, or your patient who you were really, really worried about, they end up not following up to do the imaging that you ordered. I think to avoid all of that headache, I think it's really worth it to be able to do imaging on the spot and get more information. Are we getting anything in the chat from our NPs and PAs?
No, not anything. I'm going to put it in here
No. Okay. Okay, got
again.
it. And what's the impact on the actual urgent care practice? You get to decrease the referrals, you're offering expanded services and potentially be able to see patients with somewhat more complex presentations, right? So moving away from runny noses and coughs as much as like, hey, we can see other patients, maybe someone with a flank pain, abdominal pain, and really expanding that. You're guaranteeing patient compliance with imaging. You're getting more satisfied patients and providers, and you have an opportunity to increase your revenue, not just by potentially increasing patient volumes, but actually by direct billing. So POCUS both improves care and brings additional revenue for the urgent care practice. And is this the poll question that you already did? I'm not sure.
Yeah, that was that. Yeah,
Okay.
I guess we got that one in a little bit early.
Okay, got it.
So again, that poll question number 6, feel free to everybody go in. Yeah, it still looks like improved patient care is the main one. Additional
Okay.
revenue had one vote, patient satisfaction. I think efficiency is really, really huge, and you touched on that. But like you said, I mean, all the additional steps that have to take place, you're waiting on the radiology person, you're waiting on a radiologist to read it. I mean, it may be 30 minutes to an hour or even 6 hours before you get a definitive answer back. And then the patient goes home and just all the unnecessary phone calls, staff time. You've got a room that's tied up for an extra hour. But if you can, really take this and get you don't need all of the detail that the radiologist is offering. You got to answer one question. And this really does a good job with that.
I totally agree. And I would love to do a study on efficiency.
So take that as a hint, everybody. If anyone is
Yeah.
wanting to get published in the Journal of Urgent Care Medicine, you've got a partner in crime here. So get some research projects going.
All right, and I'm going to switch gears here a little bit, and we're going to talk about implementation. So, what do you need to have in place to be able to offer POCUS services in a safe way and a compliant way? And number one, you've got to have someone on the ground who's the POCUS champion, who's going to kind of be the point person in case ultrasound device is not working, they kind of know who to contact. Or you have a new provider who's coming in who might need some credentialing support specifically related to POCUS. So they could be the point person to go to. Number two, and depending how big you are, especially if you're part of a healthcare system, you really want to have your IT team and biomed team kind of early on board with this project, because they might have a lot of restrictions, what kind of software you can use. They might also have preferences on what kind of device manufacturers you need to be using. So I think involving them early is really good idea. Of course, you'll need some devices, and as I showed you, there are all kinds out there. There's a ton to choose from handhelds to laptop systems, the card-based systems, wireless, wired. They come with different packages. There's a lot of AI features now, especially if you have a lot of novice users. AI features can be really helpful. So really, first figuring out what is it that you're planning to do, what kind of exams to perform, and then figuring out, what device you need to purchase is the way to go. Another thing to think about is how are you going to store your images? And if you are planning to credential providers and have a quality assurance system, you also need a way to have some kind of software to help you manage that QA. You need to have protocols and clinical pathways in place. And by protocols, I mean, what are going to be your credentialing protocols, infection control protocols, and I think having clinical pathways is key to have POCUS be used safely and efficiently in your urgent care, especially if you are having mid-level providers staffing the urgent care. I think it needs to be very clear, hey, this is when POCUS is indicated. You need to have documentation templates in place, and that's once again for medical legal reasons, and also for billing reasons. And I'll go over what you need to have in your documentation in the next, I think, in 2 slides. Of course, you need to get your provider's credentialing, and that's the next slide I have, what that involves. But basically, the point of credentialing is to make sure that your providers are confident in point of care ultrasound before they start doing it on patients for diagnostic purposes. You do want to have some kind of quality assurance process in place, and usually that involves doing clip review to make sure that your providers are accurate when they are using ultrasound and they are also obtaining quality images. And then if you're a part of a bigger institution, your providers would need to get privileges. If you're an independent urgent care, that probably you can skip that step. All right, and finally, once you have all of that in place, you can start billing for ultrasound. And all the kind of the words in orange red are actually part of the workflow. So POCUS workflow, when you're building it, you're trying to figure out how to make this the most efficient and seamless. So what does it take to award POCUS credentialing to your providers? All right. Well, this is based on ASAP and AFP and AIUM guidelines. But basically, usually there's some kind of passive learning involved. Either it's, some online content, maybe ebooks. Then you really want your providers to get some hands-on experience. Usually, it's a 1 or 2 day workshop. There are tons of workshops out there right now that they can get CMEs for. ASAP always offers a ton of them, and there's some independent parties that offer them. And then there is a period of this of preceptorship. So once someone kind of knows how to use the ultrasound, they're still not competent in using it. And that's where this preceptorship period comes in. It is recommended by ASAP and AFP that at least 25 exams of each exam type need to be reviewed for quality before the provider gets credentialed. So if someone wants to get credentialed in doing lung ultrasound, they should have 25 of educational scans reviewed first before they would go on to make clinical decisions based on their scans. Having some kind of assessment is a great idea, whether it's using QBank online, whether it's the quality assurance piece that we talked about a bit, or a more formal assessment at the bedside. And then you've got this maintenance of credentialing, something to think about. Once your providers have become credentialed, what are going to be their requirements to continue learning and keeping up with their POCUS skills? So usually that's either having some kind of CME requirement. ASAP was recommending 3 to 5 hours of CME every 2 years, requiring your providers to do a certain amount of ultrasound scans per year. So usually the average is doing 10 of each exam type per year, and then doing the quality assurance piece, so reviewing 5 to 10% of all exams that your provider does for quality. So what are some requirements for billing in terms of storage and documentation? Well, number one, order is a really good idea, although it's technically not required. Order is something that clues the coder in to look for your procedure note. So do put it in order if you do POCUS, if you're doing POCUS. You do want indefinite secure archiving, and that's a CMS requirement. So whether you have a PACS system or there are a lot of devices come with cloud storage that's HIPAA compliant, but definitely you have to have that in place before you can start billing. And then you need your procedure note, and the procedure note, you got to put in your education, the views you obtained, your findings, final impression, and the time and date you performed it. Pretty standard. And there are templates for that you can create. And very importantly, you got to document medical necessity. If you don't do that step, you are not going to be getting paid for your ultrasounds. So when I think of what a robust POCUS program is, I kind of think of these four components. One, the workflow needs to be as seamless as possible so that your providers want to do POCUS. Right. So think about it. The more kind of automated you have it, the more likely they're going to be doing it. You want it to be of high quality. That means that your providers need to be confident and focused, and you need to have some kind of quality assurance for your program. It needs to be compliant, and here I mean compliant with your credentialing protocols compliant with your state's requirement for supervision of mid-level providers doing focus, for example, of procedures, and compliant with your institution. If you're part of a bigger institution. And I'm a firm believer that a POCUS program should be profitable, right? POCUS comes with its own CPT codes. You have an overhead investment to get this started, and you're doing something really important for your patient. You're improving their care, you're expediting their care. Um, so I think billing for this just makes sense, especially because you want to be able to upgrade your machines, offer CME to your provider, POCUS CME for your providers. So all of this can be put back into your POCUS program as well. All right, so we're going to switch gears and talk about ROI. And this is I believe this is our last question.
All right, so the last poll question here, let me pull that up. All right, so the last poll question, what types of private payer contracts do you have? Pick one option that best describes your practice. So if everybody can go in here, all fee for service, all flat rate, mostly fee for service, mostly flat rate, or equal mix of both. And I think I just put that in as a chat question. Because we hear that from a lot of groups, and I think that that's contributed to the acuity degradation. Is it regardless of if you're seeing a cough and a cold, or if you're seeing a more complex laceration or abscess, or somebody with chest pain, they're going to get paid $100 regardless of what it is. So it's interesting to see. So mostly fee for service, equal mix of both. Everybody weigh in and chime in here. What is the reimbursement, set up for your particular practice? And is that something that may cause roadblocks if somebody's wanting to implement an ultrasound program? If they're not going to get paid for it, is that something, or why, if they're not going to get paid for it additionally, what would make them want to do it? And is that, how would somebody overcome that barrier?
Yeah, and I think, look, even if you are mostly flat rate, you have flat rate contracts. I do think a POCUS program is worth it, worth the investment, just to be able to take better care of your patients, but also being able to attract potentially and differentiate yourself from other urgent cares, right? So you're building patient loyalty. Um, you might be able to treat more complicated presentations. So there's still benefit of doing POCUS, even if you can't do direct billing
Mhm.
for it.
So you may end up benefiting more financially indirectly by having that service.
Exactly.
Your customer
And this is
base knows that it's
mhm.
available, and you're not referring people away. No, we can handle that. Yeah, come on in.
Yeah, and this is a slide where kind of like the way I think about POCUS. So there's like the direct reimbursement and then more indirect kind of financial benefits from POCUS. So obviously there's direct billing, it comes with CPT codes, you put procedure and you bill for it. You put in a procedure note and then you bill for it. And then there's also an opportunity, say your CPT codes for POCUS, they're not part of your private payer contracts right now. You still can use your POCUS, doing POCUS and interpreting it to increase your E&M code complexity, right? Because you're interpreting a radiology study on your own. So that's kind of a more direct way. And then the indirect way is like I'm thinking more about the quality of your care, right? So you're decreasing your ED referrals, you're potentially reducing your bounce backs, you are increasing um, elevating a patient experience by using technology and educating them, right? So there are all of these things that I put into the quality measures kind of bucket. And then the next thing is it improves efficiency. So it potentially lets you see more patients because you are avoiding unnecessary INDs, you're avoiding phone calls and arranging follow ups, and instead you can concentrate on seeing patients. And kind of the fifth bucket I think about is the cost savings that come with offering ultrasound for the patient, for the healthcare. And it really depends on your contracts, right? If you're participating um, in a contract where you are trying to bring down healthcare costs in general. And then another cost saving component is if you're already struggling with shortage of X-ray techs or ultrasound techs, right? Training your own staff, like your providers, to do ultrasound could be a cost saving step for you as well. Uh, Here I just have a chart of kind of the typical reimbursements for point of care ultrasound CPT codes from direct billing, and these are global Medicare reimbursements. And I just highlighted kind of the minimum for lung ultrasound, which is $56 of global payment, and fast is $180. So that's kind of your range. Like a one leg DVT study is $116. Um, and this is for procedural over here. So kind of the bottom of it, and it's additional amount you're going to get paid on top of doing the procedure. So $28 for arthrocentesis, to $57 if you're doing ultrasound guided foreign body removal. And here is an urgent care practice that's doing POCUS, and uh, this is how many ultrasounds they are doing per month. And this is a bit of an estimate, but this is kind of the additional billable amount that they get if they are doing this many ultrasounds. Right, and of course, it depends on how many sites do you have, how many do you have an X-ray tech that's reliably there, et cetera. But this is just to give you kind of a ballpark of where this could lead, or where it could be.
And I think, yeah, for anyone who's affiliated with a group, if you've got 5, 10, 15, 20 or more clinics, making the investment into bringing this modality on board, those numbers quickly multiply to, much larger, and could definitely have a big financial impact for sure.
Yeah, and this is, remember, we are also not including procedural guidance here, like more advanced ultrasounds. And these are all kind of using Medicare
Mhm.
fees. So if you have a lot of private payer contracts that might be paying you more for POCUS, your reimbursements might be even higher. And I would encourage you guys to scan this QR code. I have a free POCUS ROI calculator on my website where you can actually plug in kind of the estimated number of POCUS procedures you're going to be doing, and you can put in your payer mix, and it will spit out a number, kind of an estimate of what would be the billable amount monthly and annually for you. And I'll have this QR code up later on as well. All right, so I think this is pretty much our kind of last points over here. But what are some reimbursement challenges? Number one is lack of documentation. So if you didn't put in that procedure note, or if there's no order, you're just not going to get paid for it. What are the most common reasons for denials? Insufficient documentation. So you did do a procedure note, but there is no medical necessity statement, or repeat imaging by the same provider would cause a denial. Um, and the issue with private pay contracts is sometimes the POCUS CPT codes might not be part of your contracts, so you would either need to do a carve out or wait for to renegotiate your contract. But meanwhile, you might be able to kind of raise that E&M complexity instead of doing direct billing for POCUS. All right, I wanted to show this really happy puppy in the snow. And I am done, so I'll take some questions. This is a QR code for the calculator.
Awesome. That's a beautiful dog. Is that your dog?
It's not my dog, but I loved this happy dog. And I didn't want to leave people hanging with ice cream on the pavement.
All right, so we'll go over to the question and answer. There's only a couple here, so if anybody else has any questions, please put them in here. I know that there are questions brewing around in your head. The questions that we've got, I think we kind of talked on this one. Who can perform the exam, and do they need to be certified? You talked a little bit
Uh,
about that.
Yeah, so there's kind of a certified versus credentialed, two different things. So credentialing is something that happens internally, while certification most of the time is external. So ASAP and IOM both put out statements that they do not require nor support certifications necessarily. However, because certifications can vary, right? So different third parties can offer certification programs and the quality might really vary. So it depends. It really depends. But yeah, and ideally, what you want is your provider to be competent. And what can happen is sometimes the payer can ask to show kind of proof of, their competency and being able to pull up like, hey, they got CME for this POCUS workshop. They did this clip review thing, or they got this certification, and they followed our credentialing protocol. That would be helpful in terms of medical, legal, and like billing perspective.
Another question, I threw this one in here myself. What's the time frame for all of this stuff? How long does it take to go from, oh wow, this is really cool, I want to do this, to I'm scanning people and getting reimbursed for it?
Yeah, I would say 6 months to a year is the typical norm because remember, if you really do want to kind of build this high quality program where your providers really feel confident and they are following the latest guidelines, they need to collect those educational studies, right? And it takes a little time to do those studies depending how busy they are, how enthusiastic they are. But basically, most people would need to collect 150 studies to get certified fully. Competent. I'm gonna remove the word certified
Okay,
to
competence.
competent. Yeah.
Now, if somebody here who's listening, this resonates with them, what would you recommend? What process do they go through? Do they go ahead and reach out to you? Are you able to kind of walk them through this whole process? Is that part
Yeah,
of the
totally.
business model?
I'd
Tell
love
us
to
a little bit
connect.
more about Hello Sono and what you do.
Yeah, I basically I work with primary care and urgent care practices to kind of help them started on this journey. So, and it kind of figuring out, how are we going to implement it, what's required, what are the clinical pathways, and then also offering education for the providers. So from custom workshops to actually the clip review to get them competent and by following the latest guidelines from ASAP and AFP. So yeah, do reach out at info@hellosonar.com. I'm also on LinkedIn and I would call it pretty active on LinkedIn. So you can also message me on there.
Yeah, so I think if you are interested in this, you may have to kind of brand yourself as the ambassador, the internal champion to get this moving. Maybe have a discussion with your medical director or chief medical officer and say, hey, this is something that I think we need to explore. Let's reach out to Tatiana and let's see what we can come up with, and just kind of start that process, start the dialogue, start the communication, and get the ball rolling, because it's not something that just, hey, this is really cool, I'm going to start doing it next week. There's definitely a lot of compliance issues, regulatory issues, training, proof of competency, making sure that all your ducks are in a row so that you don't, expose yourself or your organization to any liability.
Totally. And that's part of the reason why I started Hello Sono because we were getting a ton of people, including myself, like purchasing devices, right? When they became affordable, we were using our CME money to buy handheld devices. And then they ended up also being used by people who are not trained in using POCUS. And that's concerning, right? Because it's definitely operator dependent. So you really need to achieve that competency level to reliably use it.
Well,
Um,
does anybody or anything else you want to chime in, or one last
Yeah, I was
thoughtful
gonna say,
question?
if any of you are going to be participating or going to the urgent care convention in Vegas in April, I'll be speaking. there as well on POCUS and urgent care, and I'd love to connect with you guys in person there. So do let me know.
All right, let's see here if there's anything else. Yeah, so in the chat here, we've got some LinkedIn connections with myself and with Dr. Haverlook. Hello Sano's website is in here. Really encourage you all to take a look at this stuff. Go to the JUSUM.org website, do a search for POCUS and learn what's going on in the urgent care community in regards to this topic so that you can kind of get up to speed and see what other people are doing in the urgent care setting when it comes to this. Um, let's see. Yeah, so Anna West right here. We will be there as well. Would love for you to speak with our medical directors. Well, come over and find her or send her an email and go ahead and set up an
Awesome.
appointment before you get there. Um, yeah, the UCA is a great opportunity for people to network and connect and collaborate. Having those sidebar conversations at the booths and all of that stuff. Great opportunity for people to connect. So let's see here, just to make sure, see if there's anything else here in the chat or any questions. Doesn't look like it. So I'll go ahead and wrap everything up here. We've already gone through the questions and now, just some closing remarks. So we hope that everybody enjoyed the event sponsored by EB Medicine, Saruka, and Hello Sono. Hello Sono is offering a 15% discount on all its services to both EB Medicine and Saruka members. This offer is limited time, so you do need to act fast. As we discussed, connecting with Dr. Tatiana here on LinkedIn or visiting hellosono.com to learn more. So I'd like to personally thank everybody for joining today. I know you're working or you're on your time off. Regardless of where you are, your time is valuable, and we really do appreciate you for joining us today. A big thank you to Tatiana for being our expert today and providing us with really a terrific presentation, very eye-opening and informative. We appreciate your time for putting everything together. Everyone who registered will receive an email with a link to the recording within 1 week. And that's something that you can share with your medical director. Share this with them and see if you can get that conversation going. But you can also post additional comments and questions on EB Medicine's private Facebook group, which is entitled EBM Urgent Care Clinicians. And I think, Val, if you could please put a link to that Facebook group where we really do go in and share just a lot of free informational content, polls, questions, trying to stimulate some dialogue about what's affecting you in the urgent care community. And also, lastly, to mention and thank Saruka, the Southeast Regional Urgent Care Association, for co-sponsoring the webinar today. Please check out the Southeast Regional Urgent Care Association, and the website is www.seruca.org. This is a new organization. It's one of only, I think, 3 regional urgent care associations under the UCA umbrella, and it's designed to promote urgent care education and advocacy specific to the Southeast. We've got our first in-person conference, which is going to be along with the Southern Medical Association in Atlanta in October. So if you would like to get involved with Saruka, please connect with Dr. Bernie Short through the website, which again is saruka.org. So in closing, thanks everybody. Thanks for being here. Thanks for attending. Come into the Facebook group, reach out to Dr. Haverlook through her website or on LinkedIn. And let's see here, there's a couple more things in the chat. So just let me make sure I'm not missing anything here. All right. Yep. Okay. Yep. So it seems like I think we've got everything covered. Are there any closing remarks? Anything else that you'd like to throw out?
I really just thank you. Thank you for moderating, and thank you for everyone being here and being open to doing something cool, doing POCUS. I think I'm very excited for everyone, and I hope you guys learned something new today.
Absolutely. I think, another thing she and I were talking before we got on about acuity degradation. And, this is an opportunity for us to be able to do more than just managing coughs and colds and flus. We really can help expand the offering of things that we can diagnose and treat and manage in the urgent care setting by expanding our horizons a little bit and really taking the initiative to learn more. So I think this is a great topic for all of us in the urgent care community to be more familiar with. So thanks everybody. And you can, to exit, all you have to do is simply close your browser window, and wish everybody a great Thursday and a great weekend ahead.
Thank you.
Thanks everybody.